Hi, everyone. Thank you for your patience. We'll get started soon. Looking at the PowerPoint, it definitely won't take us a whole 2 hours. We'll definitely have more than enough time for questions. Just going to wait for Dr. Jafari to log in, and then we'll get started. Okay, guys, we are gonna get started. First, we're gonna get started with Kahoot questions. Let me share my screen. And thank you everyone for joining. And I hope so far core week has been not too bad and you guys are happy to be done with exams. Thank you, Jessica. Thank you. Thank you, guys. So this is kind of more of just like a poll for the first time to kind of go over, see where you guys are starting at, and then we'll kind of cover all of the questions and the answers a little bit later. And then at the end, we'll do a Kahoot that kind of solidifies everything. So feel free to answer these questions as honestly as possible. So that way we can make sure that we answer any questions or confusions that you guys might have. All right, I'm gonna get started. So assuming normal peak pressure is less than 40 and plateau is less than 30, which of the following represents an increase in air resistance? Okay. So same kind of perimeters of peak pressure being less than 40, plateau less than 30, but which one represents a potential pneumothorax? Okay. And we are definitely going to talk about this a little more about how to define which one's reliable or not. Okay. So this one's kind of focusing on the CO2 graph and what would be representative of oversedation. And then which one would correlate with a patient rebreathing CO2? And then, so looking at this flow curve, which of the following situations are kind of represented? And then what is the option for fixing the following flow, pressure, and volume curves? And then what is the best indicator that a patient is ready to be weaned off ventilation? Okay. And then last question. All right. So at the end of our session, we'll take another Kahoot and see how much we kind of learned. And now we're able to start the presentation. Again, if anyone has any questions at all, please don't hesitate to unmute. I can't see the screen when I'm sharing. So I might not also see the chat.
Do you
Okay.
want me to monitor the chat and bring up questions?
Yes, please. So if anyone has any questions, you can use the chat, but please feel free to unmute. This is definitely a more collaborative thing. We definitely want to teach what you guys want to learn, but also help you guys figure out if you have any confusions anywhere. So don't hesitate to ask any questions. This is definitely not graded, so being wrong is definitely not something that we're all worried about here. It's more just making sure that you guys are leaving with our learning objectives, which are describing how to assess a patient on a ventilator and identify the selection of common problems that arise, but also reinforcing the understanding of the vent basics. So if you weren't at the vent basics that we hosted at your last core week, feel free to ask questions. We do have some extra time to review anything, but definitely want to make sure that everyone's kind of leaving with a big understanding. So the big component of this session is to kind of make sure that we all know how best to assess a patient who's on a vent. So the big thing is to notice that you have to look at the patient and the vent. So that means like when a patient's on a vent, you have to go to their bedside and do like a general exam, seeing if they are struggling with the vent at all, like coughing or choking or trying to take the vent out at all, making sure that they are comfortable in bed, like making sure that you do that physical exam where you're understanding and you're not hesitant to examine a patient who's on a vent, and you're not just using the vent as a way to figure out if the patient's doing okay. And so when it comes to the vent, really looking at it mechanically is a good way to start the breakdown, like looking at what the vent's actually telling you. So what the peak pressure, the plateau, and if there's any presence of an auto peak. And then what labs could tell you. So how the vent and the patient are working kind of together. So like the pulse ox, whether you're looking at the CO2 waveform or any ABGs. And then lastly, it would be once your patient's on the vent, big thing is you got to get them off. You definitely want to be able to get your patient to get stable so they don't need the vent anymore. So kind of making sure that you are understanding how and what a spontaneous breath trial is. So first thing we're going to focus on the mechanical. So this is a waveform that we talked about in our last talk about vents, which breaks down kind of the mechanics of the pressure waveform. So let me see if I can get it. So when the air goes in, like this peak pressure being the pressure of the air going in with the air resistance and the alveoli pressure, and then you do this inspiratory pause that will show you the difference between the pressure from the alveoli from the actual pressure from air coming in. So that inspiratory pause is like there's no air going in, and it's really just the alveoli pressure with the current pressure in the lungs. And these two values, I would say, the plateau pressure and the peak pressure, are big ones that you kind of keep in mind to see if anything's like going on or any issues. And we're going to elaborate more about this on the talk. And then we do have PEEP, which is a thing that I feel like we all kind of know a little bit, but are not very like comfortable or sure what it is sometimes, especially in clinicals when we're getting asked about it. So it's big to kind of remember that PEEP is like the pressure that remains after expiration. So PEEP is like on this graph, this shows PEEP as 0, but on a lot of vents to make it easier on the patient, they keep PEEP at like a 5. So like there's always some pressure going in that allows the alveoli to stay open. So it's always not like it's like a snapping open, if that makes sense. Any questions before I move from this slide?
Just wanted to point out that the plateau pressure is an active measurement. So you as the clinician have to interact. You have to do something to obtain this pressure. Whereas peak pressure is being reported for every single breath, even by ventilators that are from 1980s. It's very easy to measure because it doesn't involve doing anything to the patient. As long as the tidal changes in the pressure happens, the monitor and the ventilator would record it and report it for you. So it's much more frequent to see a peak pressure.
So that's where this little arrow right here is talking about like the inspiratory hold. So like pausing the flow of air during inspiration. So once like that breath goes into the patient, kind of pausing the flow so that you could measure that plateau pressure. So let's start off with, we have a patient who's on a vent. This is like their normal pressure. And then all of a sudden, like maybe their ET tube, like the intratracheal tube gets kinked, or there's mucus plugs, or they start having like those bronchi spasms. So there's something with the airway that's really causing resistance for the air to go in. So that kind of results in the pressure waveform to like increase in its peak pressure. And most of the time the plateau pressure decreases because of the pressure between the alveoli are going down. But I've also seen in some sources that sometimes they just say this as normal pressure. So anytime that you see that peak pressure jump up, the plateau pressure most likely should go lower, but could also be normal and still kind of be considered in this sense of having that increased air resistance, which is that big way of saying like, okay, something's going on with the ability for the air to get into the lungs itself. And so like that's a way we're like, okay, so it's not the vent technically, but it's more of like, okay, the vent and the patient are communicating in the best way. So big summary out of this one is knowing that high peak pressure, low/normal plateau pressure equals an air resistant issue. So again, we have another patient. Let's say that they're having some fibrosis issue, atelectasis or a pneumothorax, like something that their actual lung itself, like the parenchyma of the lung, is not able to do its function. This would cause the graft to have an increased peak pressure and plateau pressure. So meaning that there's a lot of force that needs to go in to get that air in, but also the alveoli are under a lot of strain also. So like there's an elevated of both the peak and the plateau pressure. So like high peak, high plateau, there's a lung compliance issue, meaning the lung's not able to get the air in the best way that it should. So kind of summarizing this on this table, so like high peak, low plateau, high air resistance. So this could be a kinked ET tube. So kind of doing your physical exam, making sure that the endotracheal tube is fine, a bronchial spasm. So definitely kind of reviewing the patient's history, any medications they might be on, and figure out the best way to kind of move forward with that. And then mucus plugging. That's another, like, it's kind of like an intervention that you kind of have to do so that like the flow can get back into the patient's lungs. And then high for both is something wrong with the lungs itself. So like when you see a patient and they're post-op and they're doing their incentive spirometer, like it really is important for them to do, because they do need to make sure that they're not getting atelectasis, because that can cause it to be a little bit more difficult for them to breathe. And then the one point at the bottom that we didn't really talk about is when both pressures are low, that leads you to think that the vent's not able to actually get a high enough pressure, meaning that there's not that sealed airlock around the system. So like the air is not able to go straight through. It's kind of like dispersing before it even gets to the patient, leading to that low peak pressure and the low pressure kind of experienced by the alveoli. Any questions? So I want to like revisit PEEP, because PEEP is a very important thing to keep an eye on. So usually in a patient that's like walking around, PEEP can come down to the 0 point. But like I said, on vents, especially in the ICU, I've seen it tend to be that we keep PEEP at 5 to make it a little bit easier. You're giving a person air through a little tiny tube versus someone that, like when you're usually breathing, you have your mouth, you have your 2 nostrils, but now this person has a little tiny tube to breathe through. So PEEP makes it just a little bit easier to get air in and out. So the big thing to notice is that if you start having auto PEEP, so if PEEP starts to increase without you increasing it, so let's say you leave it at 5, but you're starting to notice that PEEP is going up to 6, 7, and 8, then this is a big thing called dynamic hyperinflation, which is when your respiratory rate might be too quick, or the patient is not getting all of the air out during their expiration phase before the vent is putting more air in. So it kind of leads to an increase in intrathoracic pressure, but also can start making the patient uncomfortable. Like they could be wheezing, like getting that air trapped is important. So like really making sure that like, okay, like you see this on the screen, but like also the patient might be the first thing that like kind of brings your attention. Like the nurse might say, hey, the patient's really uncomfortable right now. And you go in there and see the patient's like trying really hard to try to get air out or is wheezing, and you're noticing the, like looking at the vent, this PEEP, it's best to try to solve this by bedside. And like the easiest way to try to fix this is kind of lowering their respiratory rate so that the vent isn't beating the body out of getting the air out, or elongating the time of expiration. So allowing the patient to have a longer time to get the air out. Any comment you want to make, Dr. Jafari?
Any questions? I just wanted to point out that as I say to all medical students, the only way that you can differentiate how the patient looks that is abnormal is to look at lots and lots of patients. So every single patient that you see, invest in doing a close examination, and by examination mean looking at them, paying attention to their respiratory rate, paying attention to their work of breathing, how much are they putting in to be able to breathe. Most patients, if we're doing a good job, would be normal. So that gives you a baseline, and you can compare it after you've seen hundreds of these patients. You can compare it with someone who is not looking that way, and you say there's something wrong. And that would be your trigger to figure things out. Otherwise, this auto-PEEP can be completely missed.
Yeah.
Is there a common setting or like a common patient that you tend to see auto-PEEP or like dynamic hyperinflation in, or is it just going to be any patient on a ventilator essentially?
It's mostly patients with obstructive lung disease. So your emphysema patients, COPD patients, they're generally limited to the medical ICU population. So surgical patients are not as common to have this problem very frequently. However, if you're making the patients too uncomfortable, so your sedation is not adequate, which if you're interested in learning, you should definitely prepare to listen to Courtney talking about sedation at some point. But once you have your sedation not adequately administered, then the patient will become agitated. They would go dysynchronous with the vent and frequently either try to squeeze their chest and create essentially a force against the inspiration, or will bite the tube and prevent the exhalation to happen. So if the ventilator, some ventilators are very smart and can adjust for that, but if the ventilator doesn't pick that up, that can also lead to auto-PEEP. Did that answer your question?
It did. Thank you very much.
Mm-hmm.
Okay. So this is another visual that we saw in our poll questions that's showing that air is not escaping. So like there's still air trapped at the end of expiratory because inspiratory is starting too fast. So looking at pressure, like the pressure is slowly climbing up and up because air is kind of getting trapped, causing that P to increase in flow. So this is like inspiratory, then you have the expiratory. And like you can see that before the expiratory really finishes, the air gets put back into the lungs before it can actually finish. And then you have the volume of the lungs here, and you can see how it's slowly climbing because the air is getting trapped. So again, assessing patients. So we're going to go now to the physiology. So obviously the post-ox, but the big thing is oxygenation. So I feel like one of the big questions that I got during my ICU rotation was, why do we care if the post-ox is at 93 over 90? Like, why is that such a big issue? And really understanding that this graph, when it comes to oxidation, that there is kind of like a plateau aspect of when you're at that 90%, 90 between 100 is still kind of near the same range, but like once you drop from 90, you start going really far from having the amount of oxygen needed to the patient needs to have. And so like really understanding like, okay, like a 93 is worrisome, but if the patient, let's say the patient has like COPD or a lot of other pulmonary issues, that 93 is not as concerning as, let's say, a 90, but like a 95 is not what we have to push to if like our goal is trying to vent a patient. I had one patient that had a long history of COPD, and we were really trying to get him off the vent so like we could get him out of the ICU. And it was more comfortable to have him at like a 95% or 94% instead of trying to push him up to a 98%, because that just kind of made him more reliant on the vent. So kind of understanding the oxygenation curve doesn't go away when you get to clinicals. But the big thing to know is that like if your pulse ox stops, like you do have other things that you should check. Like if your pulse ox drops, you should make sure that you're having a reliable waveform, that like it's not the pulse, it's not the patient that's causing an issue, but actually like the equipment that's causing you not to have the waveform that you need. And if the waveform's unreliable, you can get a stat ABG and kind of start that process. You can figure out where the patient is, whether it's acidotic or alkalotic. And so looking at these graphs about what is more reliable, but so this side being reliable, it's important to remember that with the pulse ox, it's kind of it's measuring the amount of oxygen kind of per pulse is a way to think about it. So the level should correlate with the pulses of the heart rate. So like this correlates with the pulse of the heart rate, correlates with the pulse of the heart rate. And even though this one doesn't look pretty, it still correlates with the heart rate. Because if you notice, the heart rate is irregular right now, and it still correlates with the heart rate. Versus on this one, either the pulse quality is poor, like it doesn't even really follow it, or it doesn't correlate with the heart rate at all. Like the heart rate's kind of all over the place with this patient, and there's not really a good waveform going on. Pausing in case anyone has questions.
Just pausing for a second to appreciate the fact that the pulse oximeter, the plethysmograph, is actually somewhat of a poor man's arterial line. Pay attention to the red line being an arterial line and see how it very closely resembles the pulse ox. It basically is showing you that there were some pulses because of the dysrhythmia that the patient has. They had not received enough preload, so their output or their stroke volume was smaller. And then when they got a bigger pause somewhere in the middle, then you see that it slowly starts building up and the waveform becomes bigger, and corresponding to that, the pulse ox also gets bigger. So it is kind of advanced to be able to pay attention to these subtleties, but the pulse oximeter is a really interesting second by second surrogate of your tissue perfusion.
So then we're going to go to capnography, which is looking at your CO2. So your inspiration, obviously, you're taking in oxygen, so this should be going down, versus when you're expirating, that's when because remember, it's measuring kind of what the patient is blowing out. So that's why the expiration is going high, because you're blowing out CO2. And then you have your end tidal when you kind of switch from expiration to inspiration. So what can go wrong when it comes to measuring for CO2? So you could have like no waveform that could show you like, okay, am I having a tube malfunction? Because there's no way this patient is not breathing out CO2. Maybe they're not being ventilated, maybe the sensor's not working. So kind of making sure that you don't forget that you are balancing a patient with the machine. And so machines can go faulty, and it could be more likely and easier to fix if a machine's going faulty versus if there's like really a big issue with the patient that needs to be solved. So always a benefit to really check the machine and make sure there's no issue with the machine before you really start making big changes in patient care, because it could be a really quick fix of like there's just not a correct CO2 monitor on that machine and the patient's actually fine. And that's a much quicker change than trying to kind of work through the pathophys of the patient and you didn't even think about the machine not being malfunctioning. So different ways that it can go on. So this is our PaCO2 and our end tidal. So if both of them are increased, does anyone know what that could kind of mean?
Anyone? You can be wrong, it's allowed.
It helps us know where we have to go.
So does it mean that if your PaCO2, I really have no idea, I'm just kind of like reasoning it. Like if your PaCO2 is high, that indicates, and your expiration of it is high, that indicates that it's not like necessarily a lung problem. It's just you actually have a high PaCO2, which could mean something like an acidotic process or something like that is going on and causing the PaCO2 to rise rather than something, unique to the lung.
Most of the reasoning was correct, except the part that acidosis is the result of something else, not the cause of the rising PCO2. The PCO2 gets retained in your lungs if you don't breathe adequately, right? And your brain regulates it with your respiratory centers. In fact, your brain has receptors for PCO2 measurement. And as soon as it goes up, you start breathing faster. Courtney, you want to reveal the answer?
Yes, so like this can happen in any type of way that's kind of trapping air into, so whether that's pulmonary embolism, obstructive lung disease, ARDS, sepsis, anything that's going to kind of cause, like, will cause this like elevation. And then we have when they're both decreased. Any thoughts? Wrong answers are welcome. You don't have to be right.
Is that just like hyperventilation?
Do you want to talk a little bit? Yeah.
Yeah, that's one way of it. Can you think of any other? Anyone else? Jessica, I have to like call you by names one by one, I guess.
You're the attending. I don't know if I want to do that just yet.
I was also thinking about hyperventilation. I was just trying to think about how, you know, they could both be low. I mean, if like an air trapping process is causing them both to be high, then I'm not really sure what could cause them both to be low unless like, or just diffusing really easily.
If you don't have, absent presence of anything that will basically block CO2 from going from one side to the other, then they should correlate very closely. And I think Mike had a good idea of that if you breathe faster, then you blow off CO2 faster and it goes down, and then your entitled might actually also show a lower gradient. But it's always important to do the mental exercise of trying to answer these questions, because it helps you kind of conceptualize the idea that these two should correlate with each other fairly closely within a few breaths. So once one goes up, the entitled goes up, it is the result of PCO2 going up. And once it comes down, it was the result of the PCO2 going down. Basically, you can use the entitled to estimate PaCO2. That's why when the patients are, let's say the patient is intubated and you don't want to get frequent blood gases, you can have the entitled on and then correlate it with your blood gas and say, all right, I'm seeing a PCO2 of 35 and an entitled of 35. So they're correlating, and if by tomorrow they're still the same, there's no reason to recheck it just to confirm the PCO2. There might be other reasons, but for that, I'm going to just rely on entitled telling me that the patient is blowing off enough CO2. Make sense? Courtney, what's any other conditions that you wanted to point out?
I think there was this last one where it's like unchanged or increased, but the entitled decreases. And so the gradient between the two is widened. Any thoughts on this one?
Is that just like the ventilator isn't really working? We're not like there's something wrong with the machine, or we didn't intubate them correctly? I don't know.
Yeah, that's a good thought. It's entitled generally is placed from early on. We make it a habit of placing continuous entitled monitor on patients who are intubated because it gives you a wealth of information that basically might allow you not to do like frequent blood gases and all the other measures. But once you intubate the patient, you would probably know whether it was a successful or not within a few breaths. This is more of a whether if there is a persistent widening in the delta in these two measures.
So like a dead space issue, or if there's some other issue with like actually getting like the actual lung itself. That makes sense.
So if you have increased death space,
Oh, yeah, I had a
That's a
question.
good summary.
Oh, okay, sorry. I think I actually misheard something about the first graph, so never mind.
Well, we can clarify it if you want to ask it. We have time to.
Oh, this slide actually clarifies it, because I had thought that when both were high, that was like pulmonary embolism situation, since it's like I thought that that's like something I had heard, and then I was when Minju was saying like a dead space thing, then I was like, oh, wouldn't that be this graph? And then this table clarifies that.
So yes, definitely misspoke. So it's definitely more of the mismatch between the two. That's more of the pulmonary embolism and the ARDS. Any other questions on like CO2 readings and the waveforms? Okay. So this is kind of the summary of what usual vent settings look like, just so you guys have a good idea, I think, of like, okay, like what should be more concerning, what is kind of within the normal range. So this is kind of the normal range of things, and the ABG values you guys are going to see again, so you guys don't need to like memorize them, even though I feel like some people do. But the big takeaway is that the perfect settings and lab values is not always good for patients. So depending on what the patient's history is, or what their medical condition currently is, aiming to have like perfect settings and perfect lab values isn't a goal. Your goal is to kind of maximize the patient, not kind of maximize their values in their labs, if that makes sense. You really want to make sure you're taking the patient as a whole and not just like these little parts of like just focusing on what the vents say or like just focusing on what the labs say, but also like the whole patient as a whole. So we'll have a couple examples when it comes to acid-base disorders, and we're really just focusing more on the respiratory, just because vents aren't really going to help in the metabolic. So this is really focusing on the respiratory. So let's say we're in the ICU. We have this 50-year-old male with no big past medical history, but is on a vent because this is his stats when he arrived, with a temperature of 102, blood pressure 100/60, heart rate of 100, respiratory rate 44, breathing a 90% at room air. What do you guys think is going on with this patient? Like matching the vitals with the actual pH, CO2. What do you think is going on? And we'll ignore the vent settings for now. And then just so you guys have this, so it's not like something you guys have to remember, the ABG values are right over here in the corner.
He looks like septic and like he's retaining CO2 and he's in like a respiratory acidosis.
Perfect. So, right, like he's breathing really quickly, but that CO2 is going up. So he could be at the point where he's fatigued. He's really not getting air out the way he needs to be. So like big reasons to get him on a vent where the patient isn't really breathing effectively. And so getting able to slow his breathing down and making sure that he is getting the air out that he's actually needs to get out, with like this mixed picture, but also a metabolic kind of acidosis picture because of the sepsis. So a big point also with this highlighted red that Nancy, who started the crit care kind of modules, really wanted to highlight is that you don't want the patient to have so much oxygen that it leads to radicals kind of floating in their blood. So like, even though you might start the FO2 at 100, kind of getting it to a point where you can lower it so that the patient is comfortable, but also not getting like overburdened with way too much like pure oxygen. So let's say we get to like day 2 and these are the patient's vitals, and we've taken him off of the vent. Looking at this, would you want to add him back on the vent? Would you think like this is necessary, or like how would you want to kind of move forward with this patient on day 2 being now off? Well, not off the vent. He's still on the vent. You're trying to figure out whether it's okay for him to get off of it, or you're trying to determine whether you should change anything. How are you kind of assessing him walking in on the morning? we can start with the basics. His temperature's kind of going down.
Yeah, his temperature seems like it's going down, and his like heart rate looks like it's a little more stable. Respiratory rate looks better. I would say the respiratory compensation looks a lot better. It's not like perfect, but yeah, I mean, I think you could potentially try taking him off the vent. It seems like things are improving.
Jessica, why do you think it's not perfect?
I mean, I guess I would still expect like him to be breathing off a bit more CO2, I guess, with a bicarb of 19, but
That's a good point. No, it was not a trick question. So what happens is the CO2 was building up and the patient was not able to blow it off. In fact, this is an adaptive physiologic response where when you get tired, the compensation is to just take shallow, rapid breaths, but it's not sustainable. At some point, the patient would decompensate. When you intervene and put a breathing tube in, you will be in full control of trying to ventilate this patient. And you always have to pay attention. You're already starting with a PCO2 of 60, so you're trying to go either with bigger volumes or faster breaths. If your goal is to make them comfortable, you should give as big of a total volume as it's allowed, dictated by protective lung ventilation. And once you're on day 2, you're trying to basically match their requirements. Now, this PCO2 of 40 is in the physiologic range. It will not interfere with anything, and it should be accepted as it is for now, because the patient, as you correctly identified, is improving. There's no reason trying to make them look completely normal, in other words. What Courtney was pointing out earlier, that you don't have to shoot for all these numbers looking exactly what the reference book says, but rather try to match it to the patient, identify what the derangement of physiology is, and are we moving in the right direction or are we moving the wrong direction? Does anyone want to take a guess why the pH is 7.3? I guess I can go with
It's because there's still the metabolic acidosis here because the bicarb is still low.
Yes, very good. So you have to identify that there are 2 components to your homeostasis, and for the pH to be maintained at 7.4, you have your kidneys and you have your lungs. And in the process of sepsis, the kidneys might be working at full speed and still not managing to create enough bicarb to counteract the acidosis that is coming from essentially proliferation of a microbe in your body.
so at what point would you consider taking someone off of vent? Wouldn't there be concern, like if you took them off now, that they would just get respiratory fatigue again?
Yeah. Yep, it depends on the totality of the picture of the patient. So if you're seeing that they have markers of end organ perfusion getting better, for example, the patient came in and they were disoriented, and now despite the fact that they're intubated, they can still interact with you, they can show you thumbs up, they can blink to your questions, so you know that their brain is functioning. This means that not only that enough oxygen is getting there, but even though that the pH is 7.3, their physiology is corrected to the point that is now conducive to brain function. Or you can look at the urine output and you see that when they came in, their urine output was in the oliguric range and it started picking up with your resuscitative effort. And you can look at their cardiovascular system. You pay attention that they came in and they were placed on multiple pressors, and now they're only on a low dose one pressor. And based on those things, you can say, patient is getting better, and they might be able to, they might gone on the curve of disease and health, might have gone back closer to health to the point that they might be able to be extubated and breathe on their own. However, when the patient's looking like this, we would generally try to be a little bit more conservative and maybe keep them a little bit longer on the ventilator.
So it's big to kind of keep that big picture in mind when having this patient on a vent. That again, it's vent and patient. So everything that's going on with the patient is a big thing to keep in mind as you're kind of managing them. So let's say that in another room on your ICU floor, you have this different patient, kind of similar, except he has like severe COPD, still arrived kind of with that sepsis picture. And then day 2, these are his vitals. What are your kind of your thoughts here? And again, we can start real simple. So temperature looking better, blood pressure.
Bhakti, I volunteer you to take this question.
So while we were saying the temperature looks better, the blood pressure increased. The main thing that I noticed is the respiratory rate went down from 40 to 18. But they're starting at 98%. And it looks like they're still in, well, based on the ABG on the left, it's respiratory acidosis because the CO2 is high. I think I'm just concerned. I think they're breathing fine, but the fact that they're on 98, I know we were saying earlier because it was COPD, we want them lower.
Great.
Like that, but that's my main concern.
Perfect. So when we add in this ABG, kind of how does this change your picture? So let's say they're still on the vent. So that's why the respiratory rate's 18. How do you kind of feel about their picture now?
The CO2 went down. It looks better. I'm not quite sure. Like the CO2 went down to
No, you're
90.
right. It is better. Don't second guess yourself. It is definitely better. So it's moving again, talking to that there's a range from health to severe illness, and you're trying to push the patients further away from severe illness and closer to health. And this patient is moving in which direction?
Like closer to health.
Yep, getting better, getting better. The pH is becoming more physiologic. The PCO2 is still very high. What do you think? What do you think about that?
They could just be retaining this CO2 because they're like severely COPD, like obstructive.
Right. You mean chronically retaining?
Oh, yeah.
Right. So their set point might be higher than normal individuals.
Mm-hmm. Like their baseline.
Right.
So again, keeping that in mind, like again, it's really like whole patient. So when this happens, like really for COPD, they can get like air hunger where they're kind of used to having these high levels of CO2. So they're like making sure that they don't have that air hunger of needing air. You kind of make sure you increase the tidal volume instead of increasing the respiratory rate to kind of burn off the CO2, because again, like you said, they have COPD, so their baseline could be at a higher level. So kind of keeping in mind that you more want to avoid them having any like air hunger and uncomfortability. You don't want to like fight their pathophys. You really want to make sure that you're aiming to work with it.
And pay attention that this air hunger would not be reflected in vital signs or your blood gas or your vent settings. So despite that all these things are very sophisticated tools, none of them would actually tell you whether the patient has air hunger or not. So you have to be at the bedside and you have to pay attention to the patients, how they look, and make a judgment that whether they look comfortable on the vent or whether they're really, really uncomfortable.
And then just wanted to highlight again, like this equation of understanding like minute ventilation, so like tidal volume times respiratory rate. So like really kind of keeping this in mind as you're making vent changes, that it's not just like a respiratory rate or a tidal volume, but really keeping in mind like the minute ventilation equation. Kind of a similar patient, severe COPD, but now they're 200 kilograms. And this is their day 1 next to their day 2. Kind of what are your thoughts about what's going on? Any changes you guys have to make or want to make, or Are they closer to health? So I'll start someone off. So blood pressure or temperature improving, blood pressure improving. Respiratory rate is matching the vent, which is always a positive. They have COPD, but are statin about 98%.
I will volunteer Wade to take over.
Yeah, based on all the numbers, things are looking much improved, kind of across the board, vitals wise, as well as on the blood gas. So again, with someone with severe chronic COPD, we'd expect CO2 retention. So this, I'm not sure what the patient's like baseline necessarily is, but yeah, based on all the numbers, things look good at this point.
Anything that you want to change?
I don't know what I would change based on.
So I think
Courtney?
this is similar to the last patient with COPD. So let's say this patient was in the bed. I'm surprised no one's asked me, like, what did they physically look like in the bed? But let's say the patient was really uncomfortable in the bed, even though their signs look great, like remembering to increase that tidal volume because of air hunger and not because of weight. So like understanding that, like, if you were worried about lung compliance and like chest wall compliance because like they're really heavy, so the amount of pressure that needs to kind of go in to combat like the extra weight on top of the lungs is better counteracted with increasing PEEP. Instead of increasing your tidal volume. That's really not going to benefit when it comes to that increased weight. It's really going to be better to deal with the compliance issue by increasing PEEP, because this is going to counteract that like chest wall pressure from the actual weight of the elevated BMI.
If you have to raise the PEEP to account for that and to like make the patient more comfortable, do you risk, I might be thinking about this wrong, but do you risk like over oxygenating the patient if that's going to increase the oxygenation by increasing PEEP? Like, do you have to lower the FiO2 as well a little bit?
You may. Generally, in morbidly obese, you would not really have any meaningful effect by just increasing their PEEP, because the effective PEEP, if it makes sense, there's no such thing, but if the effective PEEP, the PEEP that the alveoli we experience, would still be very much the same as like the minimum PEEP that you would give to normal BMI patients. I guess it would just be more surprising that their O2 sat would be normal still in the setting. If like they actually needed the increased PEEP, presumably, wouldn't that be reflected in their oxygenation? I guess that's another way of asking the same question. Yeah, no, and it's mostly because you're essentially trying to counteract the weight from their chest wall to allow for alveoli to open. So they essentially are not having enough alveoli open, and by adding more PEEP, you're not really correcting for hypoxia. You're just counteracting that, and it's reflected because unless you go to very, very high PEEPs, you would not really see a big change in oxygenation. Now, your PaO2 would definitely change. We go from 90 to 100 or 110 or something like that. But that still is not what you expect if you apply the same principle to someone who doesn't have a high BMI. Mm-hmm. It would be a much more pronounced effect. I see. Thank you. Mm-hmm.
So this is our last case, I believe. So this is a 50-year man. Let's say that we're going back to our first patient. We're thinking about extubating, and these are his last vitals. And then we start doing the spontaneous breathing trial and spontaneous awaking trial. Does anyone know what the spontaneous breathing trial is exactly? Or the spontaneous awaking trial? Has anyone had their ICU rotations?
We can start with volunteering Minju again.
Sure. I I don't remember exactly if I saw SVT, but I just know like we can like if they sorry, the attending did ask me, there are like 3 different criteria on that you check if they're like ready to be extubated, and then I guess before doing the extubation we can turn off the ventilator maybe for a bit to see if they're breathing on their own. And then just like I'm sure we check also something else, and then if they pass that we take it off, but I don't remember the specifics, I'm sorry.
All right, it's the blueprint. That's good. A good start. Mike.
I guess I gotta add the spontaneous awakening trial component of the question, which is a similar concept, but you're dampening the sedation to see how the patient tolerates the sedation being lowered, because you also need to lower the sedation in order to assess a patient to remove the remove intubation. Because if a patient can't cooperate with the process of being extubated or a spontaneous breathing trial, then it's unlikely that you would feel comfortable doing so. So you need to lift the sedation to kind of check what their mental status is.
Right. And both for mental status, but also the spontaneous portion of your spontaneous breathing trial would not happen if the patient is not awake. So if the sedation is too strong, then they're not going to breathe on their own, and you essentially defeats the purpose of trying to do an SBT. How about Jessica? Do you want to add anything else?
I mean, I had a question just about this patient having like such a low CO2 before doing a spontaneous trial, but I don't know if that's part of the question you were asking in terms of what the trials are.
I think that's
Yeah,
a good, yeah, that's a good point to ask, because that's kind of part of the trial.
Yeah, so the spontaneous breathing trial basically is to take so when you're putting the patients on mechanical ventilation, and we talked about like modes of ventilation in the other module, but you're essentially supplanting their entire work of breathing. So you're just doing all the work of breathing for them by the ventilator. All they have to do is to do a little bit of effort, and the patient would start getting the breath from the machine. Now, in the spontaneous breathing trial, what you do is you lower their sedation and you allow them to try to breathe on their own with a little bit of support. And that little bit of support has a very specific definition, mostly institutionally, meaning that each hospital would have their own definition of what an SBT is, but the literature also has that. Courtney, do you want to add something?
So I would say like this is their vitals and their kind of ABG, I believe, on the respiratory. So kind of making sure that if you're going, like I like the point you brought up, Jessica, in the sense we're definitely making sure that CO2 is kind of high when you're gonna get ready to extubate. It's kind of like the number one rule I feel like I've learned, at least on my anesthesia rotations, that if you really want to make sure your patient's going to breathe, you kind of make sure that their body's set up to kind of get all the triggers that they need to be like, you need to breathe. So I definitely agree that like this low PCO2 is definitely something you want to keep in mind. You want to make sure that that is a little more on the elevated side to kind of signal the brain that like, hey, we need to breathe. Because again, they've been breathing, the machine's been breathing. So on this, like they've definitely been a little bit more comfortable with the machine just breathing. So their body or their brain's not used to being like, okay, we need to take a breath. So kind of like keeping like an eye out on like, yeah, this ABG is within normal range, but their respiratory rate is kind of on the lower side, and their oxygen saturation is also on the lower side, but you just took them off the vent, and it's kind of a really big goal in the ICU, I feel like, at least during my rotations, to keep patients off vents if possible. So like, you see these vitals and you see this, and like you get a little concerned about the oxygenation and the respiratory rate, but you did just kind of wake him up after him being really comfortable on the vent. So this is a patient to watch and kind of continue to follow trends to make sure that things aren't swinging one way or the other, in the sense where like, okay, like we might have to re-intubate this patient. So kind of keeping an eye on how well that patient's kind of maintaining themselves off of the vent. So like you're not expecting to see like a perfect ABG after they just get off the vent, but you want to see that they are still kind of moving towards healthy.
The general parameters for the spontaneous breathing trial, do you have a specific slide for this, Courtney, or should I just say it now?
I would just say it.
Say it again?
I would say it.
Okay, yeah, it's basically going from whatever mode you are to a base of PEEP. So you're still trying to compensate for the fact that they're breathing through a tube and not naturally, and giving them a support on top of that PEEP. And it comes in the form of pressure. So that's why it's called a pressure support and CPAP. So the CPAP is the equivalent of the PEEP, and the pressure support comes on top of it. And there's no parameters set for your respiratory rate because you want the patient to breathe, and you will watch them how they do as they're trying to do this. At the end of 30 minutes, there are scores that you can look at. There are essentially an objective number. It's called Rapid Shallow Breathing Index, or RSBI. And if that number matches what you think is the appropriate number, in most places it's about 100. And their blood gas after 30 minutes confirms that they haven't retained too much CO2 or they haven't become too acidotic, then you can take the breathing tube out.
And I would say that depending on the institution, they might have different RSBI scores that they're comfortable with extubating patients on. So like it's never like a set score. Like one institution might be good with 80 or above, but another institution might be okay and comfortable with 70 or above. So really understanding kind of the combination of what the procedure is for the institution that you're at, but also kind of as you get more comfortable with this, also what you're comfortable with. So like your institution might be at a lower level than you are. And if it's more just you're the one treating the patient, so kind of understanding that, but going lower than what your institution says probably is a no. A big don't want to go against your institutional guidelines.
So Minju, is it all of the points that you partly remembered, or was there anything else?
Yeah, and I think the attending just one of our specific guidelines for the North Shore, because there are some numbers, but one of them was definitely being awake, which I forgot.
Very good.
It is the most important. I feel like people forget, like, oh yeah, the patient should be awake to breathe. So this is like a summary slide of all the things that can go wrong in the sense of having a patient on a vent. And so this was something that Nancy added that I thought was really helpful because I feel like a lot of people do like little acronyms. So we got DOPE dots, which is like the problems that could happen, like common problems that can happen, and then solutions. And so we'll go through this, we'll have our Kahoot, and then we'll be done way before 5:15. So if you guys have any questions, please don't hesitate to ask. So does anyone want to kind of give an idea or kind of explain what's going on? So looking at the end tidal CO2 and then our pressure waveform at the bottom, does anyone kind of have an idea of clinically what could be going on with this patient? And if you guys have any questions about the patient, I can answer that. But if we can go off of just what's going on in the graphs.
Bhakti?
I honestly have no idea.
Okay, so let's walk through it. So does this end tidal kind of look like the acceptable end tidal, or does it look funky?
It looks like lower and more of a straight line than like what you would expect.
Yeah, so it looks a little funky. So like now I'm concerned whether the CO2 is actually getting monitored correctly. There's something going on with the CO2. So then kind of looking at this press waveform, does this look normal or does this look funky?
I think that looks normal, or it should increase and then plateau.
Yeah, so I would say like it kind of looks normal in the sense where like, yeah, the air resistance or here it doesn't look too far off from the normal, but this is definitely a really low type of peak pressure to be having at a 10, and then your plateau pressure is pretty low. So like there's something going on with like the low pressure. And so we got like low plateau pressure, low peak pressure. Does anyone remember kind of where that leads us in sense to our differentials?
Jessica?
I'm just thinking there's something wrong with like the vent or the tube or something. I don't know what exactly.
Perfect. So yeah, there's something wrong with the vent. So a big thing is like, let's talk about what the patient's been doing. So like, that's a big thing that like, I was hoping someone would ask, like, what's going on with the patient? You have to remember, you were looking at one side, that's pretty much the vent, but what about the patient? So the nurse reports that there's agitation overnight. His O2 was 70%, and that when you checked on him before you left for your shift, the trach, the ET tube was here, but now when you checked, like it moved down here. So what do you guys think is going on?
Are you just ventilating one lung?
Or
It's
just, yeah.
Yeah, the tube is further out. I should
Oh,
clarify.
okay. Yeah, so you're not ventilating, or the air is leaking, I guess.
Yeah, and you're not ventilating, it's not a good seal. So like that's why you got these low pressure. So that E2 is that CO2 is really low because it's really not catching everything. And then the pressure is really low because it's really not going into the places that it needs to go. And so now we have high pressures. Who wants to walk through this line?
Wade have been fairly quiet so far, so
Let's see.
So we'll start with the first one, or you can summarize it. Good be pro at this, Wade.
Definitely not a pro. Let's see. The waveform itself, I think, is a little strange. Well, definitely on the bottom one, it seems like the peak pressure in terms of like the amplitude is what we would expect, but the plateau pressure is very low. And I'm trying to remember what that would insinuate.
Okay, so we have high peak pressure, low plateau. And then what
So
do you
is
think?
that like only one lung is functional?
No, not really, but we're getting there. So let's figure out what's going on with the patient. So we're going to observe the patient because the vent's kind of being wonky. So we're going to take a look at the patient. They have decreased breath sounds. A lot of oral secretions are noted.
Oh, so is this like increased resistance, like mucus plugging or something like that?
Yeah, so like this is like a huge airway resistance. So remember, like that peak pressure minus that plateau pressure is that airway resistance, and like that is huge for airway resistance. And then the CO, like this is a bigger gap than usual. So like there's issues with the air, like the CO2 coming out also. So does that make sense? This picture?
a physiologic end tidal usually have a plateau. It doesn't keep building up. Do you see on the, so you have a ascending arm and you have a descending arm, but you have a plateau in the middle. And the fact that this keeps building up tells me that there is an airway resistance problem. In fact, there's a specific, I don't know, do you have, Courtney, do you have a dedicated slide to this, of the morphology of the end tidals?
No.
So there is a specific pattern called shark fin pattern. When you get a spike, and you know that that is basically from some element of increased resistance, whether it is mucus plugging, whether the patient has bronchospasm, whether they're biting down on the tube, but there's a problem between the ventilator and your big airways.
And then so this is like another high pressure who kind of wants to walk through this one.
Mike?
So looking at the pressure, the inspiratory pressure is a little high, and the expiratory, or the plateau pressure is also high now. So that gap doesn't exist in the way it did before. So both pressures are high. And there's also a large gap between the pressure, the PaCO2 and the end tidal CO2. So that gap suggests that.
You look at the patient.
Let's look at the patient.
Let's look at the patient. All right, so they got a central line recently placed. There's breath sounds option on the right side, and their SpO2 is 82%.
So it seems like, so it seems like they might have like a pneumothorax, meaning that there's ineffective ventilation essentially, like, which is kind of best reflected by the CO2.
Perfect. And did it get real easier after you looked at what's going on with the patient?
yeah, it ties together pretty clearly.
Yeah. You definitely got to keep remembering. Don't forget to figure out what the patient's going on. So this one kind of gives it a little away, but we got a little more about the patient now with this one, with a 65-year-old male with a female with a past medical history of MG, ventilated for a crisis. You notice she's still connected to the vent, but there's a sudden change in the vitals. So who kind of wants to walk through what the vent is changing or showing? I think this is the last one, promise guys. I think. We have a really high elevated end tidal.
Is this apnea? Like, I don't know. The curves, the flow curves and stuff seem flat. And then the end tidal's super high. So are they not breathing?
So what are some other ways that you can have like there's these flat flow pressure volume curves?
Remember, even if the patient is apneic, the ventilator has a fail-safe. So there is a minimum number of respiratory rate that has to be delivered. So if the patient doesn't trigger the vent at all, that number of breaths would be delivered regardless. So you would still see a waveform.
Okay.
So what else could be going on to get flat lines?
I'm just going off the title, but is like the vent like literally unplugged or something like that? Like, is it the case that they're just like not? Yeah.
Yeah, guys, remember if something's going on with the patient, never forget that your top 2, top 3 options should definitely be like, is the machine okay? Like machines are machines, like you guys definitely like it's an easier fix to fix a machine than try to like go through everything that could possibly be wrong with your patient. And it's much easier to go through everything that could go wrong with your patient if you know that the machine is working pristinely. So never like, don't forget that the kind of seeing if there's like an equipment malfunction as kind of your bigger differential to kind of focus on. And it's easier to rule out than a lot of other, like it's faster to rule out than a lot of other things. Oh, this is the last one. I promise. This is the last one. So
Courtney is now
yeah,
teasing you.
I'm trying not to. I'm trying to remember exactly how many there are, but I believe this is the last one. So we have our 65-year-old male with an extensive smoking history, 2 packs a day for 40 years, and this is their vent settings. And this is what's kind of going on. High pressure. So what do you think is going on?
Minju?
Okay, so it seems like the ET and tidal CO2 is low in this patient, so there's like a big gap. And then the flow, it seems like I can't tell, but if they're like inspiring before expiration is over, maybe. And then also the pressure and the volume curve, it's a little bit funky just because it keeps climbing up. So, I'm not sure, but it seems like, okay, they're inspiring before they're finishing expiring. And it seems like they're retaining more volume. And I don't know.
You're almost there. So like they're retaining, they're building up volume. There's something going on where this patient is not getting out as much air as they're taking in. So like the breaths are kind of getting stacked. So like you were right there. I think you were just waiting for like what word to actually diagnose this with.
Okay.
So like this is kind of like the breaths are kind of either too close together or the patient is not really like this vent setting is not great for the patient because it's really just causing that increased pressure within their intrathoracic cavity. And so like this is kind of the summary where if you have like a displacement of the ET tube, the patient's like disconnect the patient from the ventilator and kind of like this, and if you have an obstruction and kind of how you fix things. And I thought this was a cute little acronym that Nancy added. Any questions before we head to the Kahoot? get that together well. And if anyone has questions while we're doing Kahoot, that's fine too. And while people are signing up, we do have our like in-person vent session at North Shore on Wednesday. In the SICU and 8 Tower at 5. And then like we'll have our crit care session about pressors and inotropes at 3 p.m. on Wednesday. All right, so similar question as before. This time we're actually going to know what the right answer is. So we got airway resistance. Perfect, guys. Good job. Okay, now we got a potential pneumothorax. So remember, so when we have that potential pneumothorax, that's like high. So like it's really hard to get air in, and the pressure within the actual parenchyma of the lungs is also really high. So this is just high for all that's like causing the lung parenchyma to have any issues. This is more if there's like a vent issue. So low, meaning that like there's something going on where air is not going in effectively. And then this is our normal. So remember, it really correlates with the heart rate. So even though this one looks really pretty, it does not correlate with the heart rate at all. This one, even though it doesn't look as pretty, it correlates with the heart rate and it matches the A-line way better than this one does. So like this one's way more reliable because it's matching everything else kind of on the screen versus this one's kind of, even though it looks perfect, it doesn't really match anything else kind of going on. Okay. So a big thing is like, so over sedation, meaning they're not breathing as often. This is definitely more of like a not having as much breaths. So like really slow with the breathing and they're kind of still kind of holding on to the CO2. So keeping in mind what's kind of going on with these pictures.
The capnogram basically corresponds, each of those corresponds to a breath. So you can basically figure out the respiratory rate just looking at that. In fact, the monitor that reports the entitled CO2 number also reports the respiratory rate.
Perfect, guys. So again, remember, so as if they're rebreathing CO2, that means that somehow they keep increasing their CO2 end tidal. Like there seems to still be some NO2 to give. C is more of like a normal of what's going on. And this looks more like a hyperventilation picture because the patient's breathing quickly, but then each CO2 is going farther down, is decreasing as they keep taking breaths. Job, guys. So remember, guys, increasing tidal volume, you're getting that inspiratory, is like you're putting in more air before the patient's able to really get their full air out. So increasing that tidal volume isn't really going to help. It's kind of going to make things worse because you're adding more air into the equation. Versus if you slow down your respiratory rate, that expiratory phase can have the time it needs to make sure all the air is getting out. Does that make sense?
Think about the respiratory cycle and the way you set it up on the ventilator. When you set the respiratory cycle to 20 and you say to the ventilator, give a second for the patient to inspire, how much time are you giving them to expire per breath? A little bit of math, but not very complicated. Anyone?
The 2 seconds?
Yes. So 2 + 1 would be 3 times 20. It's 60 seconds, which is the number of seconds in a minute. So the concept is adjusting the respiratory rate would indirectly affect your I time and E time, inspiratory and expiratory time. So whenever you go fast, you inevitably would come at the expense of expiration because physiologically, inspiration can happen at much faster than expiration. And this is what like even non-intubated humans would do, right? You would go a very, very quick inspiration and then you allow expiration to happen very gradually because there's no energy involved. It's just a recoil effect of your chest wall. And increasing the tidal volume would require more time to inspire. So that would eat into your expiratory time and that would not be advisable for this patient.
Yeah. And last question. So remember, when you have the very high BMI, you want to use PEEP to kind of combat that, the actual force from the chest wall. And then I think, congratulations, Wade, look at that. You became an expert.
Yeah, he was kind of underselling it.
It was sandbagging the whole time.
Okay, so before we log off, does anyone have any questions that they want to ask?
Doesn't have to be
Also-
necessarily in about this